So yeah, thank you everyone for coming. This is how we're doing total knees and total hips now. It's called the Mako robotic total knee system and total hip system. So not too much different from how we used to do them as far as results and things like that, but it does make the surgery easier and more reliable. The robot itself can cut about 1 millimeter and it can adjust about 1/2 degree or so. So we can make very precise kind of cuts with it. We get a CT scan ahead of time of the knee and the hip. That just helps us know what your knee looks like or what your hip looks like. And then the robot takes that into account and we use this arm to kind of adjust and tension things before we make any cuts in the knee. It is less invasive than the old way of doing total knees and total hips, and so people seem to be doing better as far as post-op pain control and things like that. So yeah, we have kind of a Sawbones model of it here that we have set up, and we can kind of go through how it works and what we do to balance the knee. So, sorry, we'll let them get the lab stuff done. So. We do use it for hips too. The more impressive model, I think, is for the knees. I think it works better for the knees as far as balancing, but we do use it for hips too, to put the cup in leg length and things like that. So this is how we do the knee. So we'll just kind of run through one real quick and show everyone. Okay. So this screen comes up when this is intra-op after we've made our incision and everything. We have the bone ready. We haven't made any cuts or anything yet, but this is the screen we see. This is how the robot registers to your knee personally. So we pick out these points and we kind of go through. So I don't know, how many points are there, John? 40. So there's like 40 different points we have to get here. And this just lets the robot know where your knee is in space. So that's the original registration process. These points are just to verify everything. It's like a second check so that we know we're in the right spot. So that's for the femur part. We have to do the same thing with the tibia. Oh, I guess. Oh, never mind. We already registered it, but we do normally register that too. So then the next part is balancing the knee. So this tells you your preoperative alignment. So most people have, it's called a varus knee, so a bow-legged knee. This model also has that, and then it can tell you your flexion, contraction, and how much the knee is bent. So we get this ahead of time. This is how much so now we're going to stress the ligaments. This helps balance it before we make any of our cuts. So, sure. So, do that. So that's our native alignment. Now we're going to do our balancing. Get it. All right. So then you do that in full extension, and you do it also in flexion to get your balance, because you want your knee to be balanced in both flexion and extension. So the next thing we do is balance this in flexion. So then this is the screen that comes up that tells us how tight we are and how loose we are. So this knee is tighter on the inside of the knee and looser on the outside of the knee. We can adjust these then to try and all be equal, because you want your flexion and your extension to both be equal so that you have a balanced knee when you're completely done. So we adjust the implants. That's what this blue is the implant. We adjust those on the screen to make up that balance. But yeah, probably a little of that. And then so Josh is our striker rep. He helps a lot with this. He's done a bunch of them, so he knows kind of what measurements I like and how we adjust them. So that looks pretty good. And then these numbers show you how much bone you're cutting and all of that stuff. So this, we have it balanced now, kind of equal in flexion, extension, equal on both the inside and the outside of the knee. So once we get that, you can scroll through the CT and look at where your implants are going to lie. So we kind of scroll through that, and we want to make sure that these look okay, all okay. So that looks good. At that point, we bring the saw in now. Checkpoint up here. Take this off real quick. You're good. Just as you normally would. Oh, we're not going to cut this. No. Huh? Dust everywhere. Yeah. All right, so this is the screen inch-op. We can adjust this. The robot can see your knee, so it will follow it around. Kind of if we move it, the arm adjusts and moves by itself. That way, when it's kind of moving inch-op, nothing bad happens. This screen shows as you're cutting. And so we want to get rid of all that blue. That's the blue represents bone that it's cutting on the sawbone. There's 4, 5 cuts we make on the femur, so we kind of move on here. Where is that? Do you have a tibial array?
It's right next to the
Oh, internal. So that makes most of the cuts, and then we have to change the saw blade for the last 2 kind of cuts for the femur. So that's what this part is. Yep. Yeah. Yep.
You get your bits at Lowe's or?
Yeah. I wish we could get them there. We might not run out as many. But yeah, so that's pretty much how it works. After that, we get rid of all the bone pieces that we cut. We put some implants in, and then you can see your final alignment with the implants in kind of here. So it's pretty cool technology. And I do think it makes the recovery quicker, and it seems like the knees are more balanced with it. So I've done it both ways. I've done it with this and with the old conventional way, and I think this way is the better, more efficient way. So questions from anyone?
Models?
Hmm?
Did you have any models?
Oh, I have some over in my office. We could get some. But.
Physical therapy regimen any different than?
Yeah, so I do the same thing physical therapy wise. The dressing and everything is the same. We use all absorbable sutures, so nothing comes out in the office, but all of that's the same. People seem to have a little bit less pain post-op because the incision doesn't have to be as big, and we don't have to release as much of the soft tissue to balance the knee now. So pain wise, it seems to be a little bit better than beforehand. So, but yeah. It does the same thing for hips. For the hip software, do we have some of the hip software? And then you can use it for partial knees. Partial knees, there's not as many indications for now, so we aren't doing as many partial knees, but it is pretty cool for that as well. So this is what the total hip software looks like. The real benefit, I think, with the total hip is it can adjust your leg length. So we get a CT of the pelvis and the hip ahead of time. It tells us that this operative leg is how much shorter? 5 millimeters shorter than the non-operative leg. So by knowing that, we know how much we need to lengthen the leg so that you have an equal leg length afterwards. And intra-op, you can get points that kind of measure that. So before we dislocate the hip, we measure that so we know how far it is. And then once we put the new total hip in, you can measure that leg length and try and make them equal. And you can adjust the head size to make it longer or shorter depending on what you need. The other nice thing is it puts your cup in. The cup is the hardest part of a total hip. You want that to be in a certain version or a certain position to prevent dislocation, and this software really helps with that. So it helps prevent your dislocation by positioning that cup in the right position. So and it has a separate arm that goes on here, but it helps kind of ream that and position the cup. So I don't think we have a model on that though. But yeah, but this is what it would look like kind of intra-op and post-op. So it shows you how your implant's going to look and what the leg length is expected to be. And it's pretty consistently right on what it tells you it should be and what it's going to be ahead of time. So, yeah. It doesn't help with the femur part of it. That part is still manual, so you still have to broach that by hand. But once you put your post in the femur and you reduce the hip down, then it helps tell how much you lengthened the leg or how much you shortened the leg compared to preoperatively. So it helps post-op with your leg length inequalities and things like that. So, but yeah, that's the only part you still do. For a total hip, manual is you still do that just with a normal hammer and everything.
Is there an attachment that would do the post?
Not yet. I don't know if they're working on that or not. I think that would be a little bit harder to do, but not at this point. So, because that's mostly you're kind of malleting it in. You take it out, put a bunch of different trials in. So right now they don't have any attachment for that. It's more just for the acetabulum or the cup part. So, yeah. Questions from anyone else?
Dr. Griffin?
Yeah.
Is there ever a reason to choose the conventional way instead of using Mako?
So for like fractures and things, it is sometimes easier to do it with a conventional way, or if you have previous hardware or something like that, and it does alter the CT ahead of time. As far as hips, I don't see I mean, I do like it for the hip because it's a second check, but conventionally, I think total hips do fine either way. So.
Do you do ceramic or metal? My sister has one of each.
So I do ceramic. Some of the health systems, WVU is good because they were able to negotiate with this, but the ceramic technically have a lower friction, so they're supposed to technically last longer, but they do cost a lot more. So that is why some facilities don't put them in everyone, but WVU has a good contract where their ceramic and their metal are the same price, so I use ceramic because they have a lower friction and less likely to wear out. So.
What's the procedure time with this opposed to the conventional way?
So I'm about equal on hips now. On knees, it probably takes about 10 minutes longer, just because you have to put the arrays in and you have to mark all the points and everything. For knees, it takes me about 10 minutes longer, but I think overall the results are better and you have less variability. So I still like it better even with that. With total hips, I'm about equal just because it saves time on the reaming, because it's just a one ream for the cup part. And so that makes up for the registration and all that stuff. So, and then for hips, you're not trialing as much to get your leg length and things like that, because you know that ahead of time. So I think on hips it saves time, and knees, it may make me a little slower now. I think at some point it will not necessarily add time, but I think the results are still better. So. But I think at UHC they've been using it for how long? 5, 6 years? Okay. Yeah. So yeah, I think, how long has this been out? 10 years?
Mako?
Yeah.
2013, I think was the first partial.
Okay. So yeah, this technology's been around for 10 or so years, so they've kind of perfected it. I think this is the second round of software for it. So it does seem to work pretty well, and a lot of people are moving towards it. I used it in residency, so this isn't the first I've used it. I've used it for 4 or 5 years before this, but it took a little time to get one here, but thankfully the administration worked with me and we were able to get one. So.
Do you always have to use cement?
No, so that's a good question. So in the older technology, we were cementing every total knee replacement. They used to cement total hips. Total hips recently has gotten much better. We don't cement really any hip replacements at this point. Knees with this, I have been cementing less because the cuts are so precise and they're so accurate that I feel like I get a good press fit on them. So some knees I will press fit with it because of that. And I think it's just because the saw is thicker than the old saw we used to use, so it doesn't skive as much on hard bone and things like that. So yeah, I've been press fitting a lot of knees, and I think it's because of this. So. Cool. Yeah, we can show the uni. So this is the partial knee replacement. You can do it for both the inside and the outside of the knee. This has made partial knees 100 times easier than they used to be, because because it comes with a little burr, so the cutting it is a lot easier than it used to be. The old way of doing partial knees was pretty difficult, but your incision can be much smaller now for partial knees because of this. So this is the software for the partial knee. Same thing, you kind of balance it ahead of time. Once you figure out where you want your implant, then this is the screen that comes up. There's a different attachment for it. It's a burr, so it just burrs out that whole area. And then your implant goes on just like normal. So.
My niece had hip surgery that went through the front.
Yeah. So I do a posterior approach to the hip. I just didn't do enough in residency of the anterior approach. The results on that show that there are about the first 2 weeks or so, you have less pain and your recovery is a little quicker. But in my hands, I'm not good enough at that approach to do it that way. So I am better at the posterior approach, so that's what I do. And it seems like after 2 weeks, the results show that there's not too much of a difference as far as the approach you do. So yeah, I don't do that way, but you can. I think can you do the anterior with the Mako? So you can use this robot to do that approach as well, and it works pretty well. So. But yeah, that was a big trend for a while, was the anterior approach. The more recent studies, I mean, it is a good approach. I didn't learn it enough, so. Mm-hmm. Yeah. Yeah, so that's pretty much it. I don't know.
Dr. Griffith, thank
Yeah,
you so much.
no problem.
Does anybody want to come up and lay on the table up here?
But yeah, you guys are welcome to come up and look at it and kind of see the arm.
If
And
anybody wants to do surgery, come on up and we'll let you do that.